Hello everyone, I am Dr. Liliana Andrade and a board-certified family medicine and geriatric physician, and today we're going to be talking about osteoporosis. So let's start. Osteoporosis is the gradual weakening of bones, leading them prone to fractures.
Think of it as your savings account is running low. Osteopenia, on the other hand, is like being financially fragile. No broke yet, but heading towards that without any intervention. Let's review the major risk factors for osteoporosis.
Risk factors can be non-modifiable, like age. Bone loss can accelerate after 50. Gender, women especially postmenopausal are at higher risk. Family history, a parental hip fracture is a big red flag. Ethnicity, Caucasian and Asian individuals are at higher risk. Then we have the modifiable risk factors like low calcium and vitamin D intake, sedentary lifestyle, smoking and excess alcohol consumption, medications including glucocorticoids, PPIs, and some anticonvulsants when they're used for a long period of time, and chronic diseases like rheumatoid arthritis, diabetes, and hyperthyroidism. Remember that this score from a DEXA scan is your go-to diagnostic tool. Being normal, more than -1, osteopenia between -1 and -2.5, and osteoporosis less or equal -2.5. And if your patient already has a fragility fracture, that's osteoporosis regardless of the T-score. Remember to order DEXA scan in women more than 65 years of age, men more than 70, and those who are at higher risk of developing osteoporosis. FRAX tool is your crystal ball for fracture risk, estimating the 10-year probability of major osteoporotic fractures, like hip fracture. You will input patient data like age, sex, body mass index, previous fractures, parental history of hip fractures, smoking status, glucocorticoid use, and conditions like rheumatoid arthritis. It also factors in secondary osteoporosis risk and alcohol intake. Here's the magic number. If the 10-year risk of major fracture is equal or more than 20%, or the hip fracture risk is equal or more than 3%, it is time to start treatment. This tool is especially useful for patients with osteopenia, helping you decide who can be treated now versus who can be monitored. Now, let's get into treatment. First, we always start with lifestyle modifications. Diet. Ensure 1,200 milligrams of calcium per day and 800 to 1,000 international units of vitamin D. Exercise, weight-bearing, and muscle strengthening exercises are key. Fall prevention like home safety evaluation, vision correction, and balance training can prevent fractures. Next up is pharmacological treatment. Bisphosphonates are the first-line treatment. Examples of these include alendronate, risedronate, and zoledronic acid. Indications are postmenopausal women and men with osteoporosis or high FRAX scores. Side effects include hypocalcemia, infections, esophagitis, and rare jaw osteonecrosis. Contraindications include esophageal disorders, inability to remain upright for 30 minutes, and renal impairment with a glomerular filtration rate less than 30 to 35. Number 2, denosumab, bronchial inhibitors. Indications for these are high-risk patients or those who can tolerate bisphosphonates. Contraindications are patients with hypocalcemia, so you have to correct it before starting these medications. And side effects include hypocalcemia, infections, and rare jaw osteonecrosis. Number 3, teriparatide, or parathyroid hormone analog. Indications for these are severe osteoporosis with a T-score less than -3.5 or multiple fractures. Contraindications are history of bone malignancies of Paget's disease. Side effects include hypercalcemia, dizziness, and nausea. Number 4 are hormonal therapies like raloxifene and hormone replacement therapy. Indications for these are postmenopausal women with low fracture risk who need the benefit of the estrogen. And contraindications are history of thromboembolic event like DVTs and PEs or breast cancer. Side effects include hot flashes and thromboembolic events. Number 5, calcitonin, has a limited use due to modest efficacy, but can be very helpful in patients who have suffered a vertebral fracture. Remember to reassess after 3 to 5 years, especially with biphosphonate, as long-term use increases rare side effects. For high-risk patients, consider transitioning to alternatives like denosumab. Thanks for watching, and remember, healthy bones are no joke. If you enjoyed the video, like it, share it, and subscribe.